I'm Mark Pegram. I'm the Associate Director for Clinical Research at the Stanford Comprehensive Cancer Institute here in Palo Alto, California. It's ironic that this COVID-19 pandemic has surfaced this year because it's right in the wake of a paper that my colleagues and I have just published on immune cell repertoires in breast cancer patients after adjuvant chemotherapy. We investigated the regeneration of immune cell complexity by comparing peripheral blood mononuclear cells from breast cancer patients between 1 and 5 years after completing adjuvant chemotherapy compared to age-matched healthy controls using mass cytometry and T-cell repertoire sequencing. The data reveal universal changes in CD4 positive T cells that persisted for years and consisted of expansion of Th17-like CD4 positive cells, memory populations with incomplete recovery of CD4 positive naive T cells. Conversely, CD8 T cells fully functionally recovered within a year. These data suggest that while CD8 T cell immunity is successfully regenerated, the CD4 compartment may be irreversibly affected. Moreover, the bias of CD4 memory toward inflammatory effector cells may impact responses to vaccinations and infections. So I thought that was a really interesting finding that we have discovered. It may have theoretical implications for chemotherapy survivors who have risk for exposure to COVID-19. And so that's my medical perspective. It's timely, it's uncanny that this happened right at the same time that we just published this paper in February in JCI Insight. So please take a look at the paper if you're interested. The lead author is Gustafsson, Gustafsson. Senior author is Goronzy, Goronzy. We met together as a group in the breast cancer program at Stanford, and we decided on some general principles that we wanted to adhere to. That is to limit exposure to patients when in-person contact is deemed non-essential, to continue to provide high quality and timely care while maintaining patient safety, and number 3, avoid adverse impact of COVID-19 pandemic on breast cancer outcomes. So treatment is still important. Cancer patients are still the highest priority here at Stanford. And so those were the general principles. Now, in terms of priorities, we place priority on newly diagnosed high-risk invasive breast cancers. Those are a high grade, hormone receptor negative, HER2 positive, triple negative, et cetera. Newly diagnosed locally advanced disease certainly falls into that category. Metastatic breast cancer falls in that category, and certainly oncologic emergencies fits that criteria. So we want to prioritize regimens that will minimize the number of clinic or infusion room visits just to decrease the risk of viral transmission. So we've decided to try to use chemo regimens that aren't weekly in particular. So instead of using weekly low-dose paclitaxel in some of our adjuvant regimens or metastatic regimens, consider a dose-dense every 2-week approach or even a standard every 3-week approach to these types of drugs, and then liberalize the use of growth factors to minimize the time that patients are neutropenic. We're considering 6 months of adjuvant trastuzumab for HER2 positive lower risk patients instead of 12 months based on literature from randomized trials, several randomized trials. So that's a consideration we've decided. Again, these are not absolute edicts that we've issued in our group, but just considerations for appropriately selected patients. We're considering neoadjuvant endocrine therapy instead of chemotherapy for ER positive patients, that's for sure. We're delaying echoes in asymptomatic HER2 positive patients, especially if they don't have risk factors for trastuzumab associated depressed ejection fraction like hypertension, low baseline EF, or age over 50. If they don't have any of those 3 risks, we decided to defer their routine echoes for a time until the COVID-19 situation improves. For endocrine therapy in metastatic disease, we're considering endocrine monotherapy as opposed to CDK4/6 inhibition upfront, again, in selected patients. And then for late stage patients who are late line getting salvage chemotherapy regimens, we're considering whether or not that's of any real utility. And we're rethinking the early introduction to palliative care or even hospice situations if need be. And the real question, our group has is, does the patient really benefit and need this next dose of, let's say, salvage ixabepiline, for example, It's unlikely that patients truly derive major benefits from that in the setting that drug and those types of drugs are usually used. We're delaying restaging in clinically stable metastatic breast cancer patients. There's a consideration now to take more interest in blood tumor markers, even though they're not recommended by any of the august guidelines committees. We don't routinely follow them in our practice here at Stanford, but that may be it may be time to reconsider that for stable patients. In patients with HER2 positive metastatic disease, we're not doing any echoes on those patients unless they have signs or symptoms of depressed ejection fraction or congestive heart failure. We're considering longer dosing intervals for HER2 antibodies, giving, let's say, 8 milligrams per kilogram every 4 weeks instead of 6 milligrams per kilogram trastuzumab every 3 weeks, for instance. And then our surgeons have delayed surgeries for DCIS and for plastics. Our plastics surgery staff is considering delayed reconstruction approaches versus immediate inappropriate cases. Our radiation therapists are rethinking of treatment of DCIS altogether. They're considering shorter schedules, as I mentioned previously. Rethinking post-lumpectomy radiation in low-risk ER-positive elderly patients is another consideration. Based on actual data, many patients probably don't need that if they're taking adjuvant endocrine therapy instead. And then finally, this whole situation has truly underscored the importance of local tumor boards. Our tumor board has become very active with many more cases discussed in much greater depth and a lot more thought about clever strategies to minimize viral transmission risk while maintaining cancer therapy outcomes. And it also, these tumor boards can save visits for consultations. So if the surgeons and the radiation therapists and med-oncs can make a recommendation during tumor board, the patient doesn't need to make round-robin clinic visits to each of those clinics in turn and can wait until their treatment is going to start to actually go to that clinic visit. We're very fortunate at my institution to have a very strong psycho services team and psychiatry team as well. And so they've been very proactive to get on board in terms of referrals. Many of those referrals can be done virtually as well. So we're very fortunate to have that as an outlet at our particular university. This has kind of been a standard of care for our patients largely anyway, because just the diagnosis of cancer itself can have strong psychosocial implications and oftentimes may require even medical treatment. For patients who are on anti-anxiety drugs, we're certainly taking the opportunity to refill those or adjust the dose accordingly. I've given patients refills for their antidepressant medications to save them a visit to their psychiatry appointment, for example. And I've liberalized the use in sleep aids. I found a number of my patients who have had more difficulty sleeping lately, and so I've been more liberal about considering medication specifically in those patients. So I think the key point is to ask the patient the question, what does their day-to-day activity look like, and what impact has COVID-19 had on them and their family and home lives in particular? And if the COVID-19 has been disruptive in any way, consider reaching out to these psychosocial support services when available. Well, this is a must. I really feel like in the current times, we are on our own. We have to hold together. Unfortunately, I don't think we can necessarily trust all the recommendations from even federal agencies. I don't want to be too alarmist or pessimistic, but in my opinion, even agencies like CDC have been too paternalistic and not making thoughtful recommendations to mitigate risk earlier on, for instance. So I think it's really key to stay together as a group between, we as healthcare providers and our patients. Our patients should ask questions to us first, maybe the medical literature second, because I think those can be more trustworthy outlets. If you see something published in the New England Journal of Medicine or in a scientific journal that's been peer reviewed, that I think you can probably say is a fair conclusion, whereas things that you hear on the television, anecdotal reports, et cetera, can be really misleading and frankly, in some cases, even dangerous. In California here, we got very lucky because of just kind of local considerations. I think our politicians were more thoughtful than at the federal level. So California had an earlier adoption of shelter-in-place ordinances, for example. And even before the state implemented their shelter-in-place edict here in California, Bay Area tech companies had already began large-scale telecommuting as a routine, which I think is truly visionary and involves hundreds of thousands of employees, even before the state recommended that. Bay Area tech was already doing it, and I think no doubt that has changed the shape of the curve here in Northern California in particular, and flattened it out far more so than the likes of New York City, Detroit, or New Orleans, et cetera. I think we were lucky because we were closer to the first outbreaks in Washington State here on the West Coast. And since many of us have, friends, colleagues, et cetera, in Washington, that may have impacted how seriously COVID-19 was taken by industry, academia, and government leaders here on the West Coast. So I think we need to stick together. And certainly the source of medical information should be from your local medical professionals. Stanford has a patient help hotline specifically for cancer patients that's available every day after 5 o'clock and on weekends and every holiday for 24 hours coverage. So that's a great service that my institution has already had in place for years, but I'm sure is much more busy now in light of the COVID-19 crisis. So that's the place to seek questions. We have online mechanisms called My Health and the Epic medical record system at Stanford, so patients can type emails to us with queries, and they can certainly make phone calls. We get a lot of phone calls, and our nurse practitioner staff and my clinic staff have been extremely helpful in fielding most of those queries and contact me if it needs to be escalated to an MD level. So we need to stick together as a medical community, as a medical professional patient advocacy, group. We've had a whole lot of support from the community. I can't thank people enough for all that they've done in providing PPE equipment to us here at Stanford. All kinds of volunteer efforts are underway. Patients are participating in screening trials here at Stanford to study COVID-19 patterns of spread, for example. So all these things are, shining examples of how something positive can come out of an otherwise negative and devastating crisis. But really, we are on our own, and we need to work together and seek advice from the professionals, not the politicians. The key principles I just want to reiterate is to absolutely maintain our, in many cases, outstanding, even curative outcomes for many cancers, breast cancer in particular. Early stage breast cancer is a curable disease, and we don't want to take any steps back from that fact. We want to maintain the high quality and timely patient care when curative intent is possible. Meanwhile, we can limit exposure to patient contacts by changing schedules of treatments, schedules of the timing of tests and scans, et cetera. All those are negotiable in the current era. And many of these things can thoughtfully be postponed until after the COVID-19 pandemic subsides a little bit. As long as those general principles are adhered to, then I think we can be creative and innovative as a community of healthcare providers to assure both quality outcomes as well as minimizing risk of infectious insults.